Good morning, everyone. It's a real pleasure to kick off our session this morning with a discussion on magnetic navigation for ablation in congenital heart disease. I should disclose the fact that I'm in discussions with Stereotaxis to support an unrestricted investigator-initiated research grant on the robotic PACES ISAC registry. So in patients who have complex access issues, I think this is where the technology really shines. And I would qualify it as disruptive for this category of patients. And conceptually, I think complex access issues could be divided into these three categories. You have complex vascular access. And so on the left is a patient who's referred for magnetic navigation due to the absence of an infrarenal inferior vena cava. Then you have complex chamber access issues. So we have lots of patients referred for ablation in the setting, for example, of extracardiac conduits. And then complex substrate access issues, where perhaps it's not that difficult to reach the chamber of interest, but then you just have difficulty getting to the arrhythmia substrate that you need to ablate. And I do believe that our patient population with congenital heart disease is really the population that benefits most from magnetic navigation. And so what I would like to do with you this morning is to review with you the basics of magnetic navigation. So what is this all about? What are the advantages of this technology? And then spend a good amount of time actually going through a case from beginning to end for you to get a good appreciation for how this technology is used in the real world. So let me first bring you to our EP lab at the Montreal Heart Institute. This is our magnetic navigation lab specifically for patients with congenital heart disease, where you see that it looks like a normal EP lab with a fluoroscopy table, but on each side of that table are these large rare earth magnets that can be swung into place to create a magnetic field around the patient's thorax to direct the catheter in three-dimensional space. And when the magnets aren't needed, they could be brought back to a stored position and the EP lab used for other purposes. This is what the irrigated RF remote magnetic navigation catheter looks like. It's really very soft and flexible. And here I'm swinging around a magnet to show you how it responds to magnetic fields. And so these catheters are then connected to motors or robotic arms. And then after vascular access is obtained, essentially the procedure is performed in the control room, where the direction of the magnetic fields and the movements of the catheters are controlled by these various joystick devices. So before we begin the procedure, our patients routinely will have either a CT scan or MRI in order for us to import those images into our mapping system. And so this is an example of a patient with an extracardiac conduit Fontan. And John will soon talk to you all about ablation in Fontan patients. In my experience, in many of these patients, the arrhythmias are located in the original right atrium in this turquoise chamber. And so if you were to approach this original right atrium from a retrograde aortic approach, well, essentially the catheter would need to go up your aorta, cross the aortic valve to end up in your single ventricle, then looped backwards to cross the AV valve, typically into a left atrium, and then find that communication between the left and right atrium to get that catheter across and into that turquoise chamber. So it's a complex trajectory that looks, something like this. And if you manage to do it with a manual catheter and get to that chamber of interest, well, even once you're there, you're going to have little control over catheter maneuverability. Now, you may be wondering, well, why would it be any different with magnetic navigation? Because after all, if you use a retrograde aortic approach, you're going to use that exact same trajectory. Well, the magnetic navigation catheter is really soft and flexible, and so it's capable of multiple angle contortions, and it's controlled by the tip with magnets embedded at the tip as opposed to at the shaft. And so here you see the catheter going through multiple hoops at 90-degree turns, and despite these contortions, the catheter arrives at the area of interest, and there you still have full control over catheter maneuverability. So it's really a step above in terms of maneuverability and precision. And so in this particular patient who had the arrhythmia in that turquoise chamber, we went retrograde aortic, and here we are. We mapped a non-automatic focal atrial tachycardia along scar border that was successfully ablated. Now, some of the other interesting features of the system are the constant contact that you get with magnetic navigation. So on the right here, you have your standard manual pull wire catheter, and you can see how in a beating heart, the contact will be variable. Even if you increase the contact force, you're still going to have variability in that contact force measurement as the heart beats. In contrast, if you look at magnetic navigation, it's really pulled into place and kept there with the magnets, and it moves with the beating heart. And the shaft is soft and flexible and acts as a shock absorber, which contributes to this constant contact phenomenon. And here you see a bench model courtesy of the University of Sydney, Australia, where they tried reproducing the rocking motion of the heart. And on the right, you see with that rocking motion how the manual catheter is sort of sliding back and forth, with that, whereas the magnetic navigation catheter looks like it's stuck in place, a lot like a cryo catheter, but it's actually not, stuck in place. You could you could easily remove it, and it's not cryo. You can use irrigated RF, a 4mm tip RF catheter, or an 8mm tip catheter. But you can see how this stability also has repercussions with regards to the ablation lesion. So with the rocking motion and the catheter sliding back and forth, you can see how the manual ablation lesion is less dense and less deep than the magnetic navigation lesion, at least in this in vitro gel model. We actually studied contact force with magnetic guided ablation in collaboration with engineers, where we created a model to mimic transvenous access and a retrograde access. And if you look at that last column of 0.1 Teslas, which is the magnetic field that we use clinically, without a sheath, the mean contact force with magnetic navigation was 6.1 grams. And if you place a sheath just at the entrance of the chamber, you can increase contact force to 20.4 grams. But interestingly, no matter how hard we tried and with all sorts of different configurations, we could not surpass 22 grams, which probably explains why this catheter is considered so safe and there have been no cases of mechanical perforation. You just can't reach higher than 22 grams because the catheter is soft and flexible and it will buckle. The other interesting feature is that if you look at the standard deviations and coefficient of variations, they're really very, very small, which again attests to the fact that the contact force that you obtain with these catheters is really very stable with not much variability at all. Here I'm showing how responsive the catheter is. And so what you do with the mouse is that you direct the vector of the magnetic field in three-dimensional space by sliding the mouse around. And with the scroll wheel of the mouse, you advance and retract the catheter. And so here you can see with these side-by-side images how responsive that catheter is. And another feature that I find really interesting with this technology is what's called ablation history, which allows you to represent in three-dimensional space the history of your ablation. And this reflects both watts and duration of the ablation lesion. So it's a function of watts times the time. And you can see that the more watts and the more time, the denser your lesions are and the wider they are. And so this allows you to identify gaps in your lesions, and it correlates very nicely with ablation lesions in vitro models. And so now I'd like to pretty much spend the remainder of our time going through just one case, but going through this case from beginning to end to show you the different steps that are involved. And so this is our case, a 34-year-old woman with heterotaxy syndrome of the right atrial isomerism type, with asplenia, a left-sided liver, She had bilateral SVCs as well as 2 inferior vena cavas that drained into the right atrium, a double outlet right ventricle, atrioventricular septal defect, a common AV valve, sinus venosus ASD, and her surgically corrected anatomy consists of right and left Glenn shunts, along with an intra-atrial fontan that directs flow from both IVCs and the left-sided hepatic vein through the atrium and to the pulmonary artery. And she also had an epicardial pacemaker for sinus node dysfunction. So let's go through that procedure step by step. As previously mentioned, we begin by importing CT scan or MRI images. So we import them, we segment them, and we annotate them. In this particular case, the patient had an epicardial pacemaker, so we imported CT scan images. And here you see rotation in 3 dimensions of the imported and segmented images. And you could appreciate the 2 superior vena cava, right and left. They're both Glenn shunts. The 2 IVCs, 1 and 2, and the left-sided hepatic vein that are directed to the main pulmonary artery by this intra-atrial tunnel. You have the right atrial appendage, you have the right superior and right inferior pulmonary veins, and the double outlet right ventricle. And here, my fellow is placing our magnetic catheter through a connector, and I'll show you what that does. We're now flushing the catheter and then placing it in this long sheath, holding it close to the tip because it really is soft and flexible in order to get that into the sheath. And then that connector is locked into place to the sheath as shown here. And the proximal portion of the connector is then locked into place in this little motor called a cardio drive that allows us to advance and retract the catheter at a distance using that scroll wheel of the mouse. Now, the Carto locator pad that's placed under the table is equipped with a special module for integration and registration. And this module allows 6 dots to be displayed fluoroscopically. So when you create an AP view, you need to make sure that those 6 dots are in your image, and that allows the stereotaxis system to be registered to Carto and to fluoroscopy. And so these 6 dots in the lower left are automatically detected by the system. And then we take still frame views in RAO and LAO positions that are then imported. And after that, fluoroscopy is pretty much no longer used because all our mapping and the position of the catheter are displayed on those still frame fluoroscopic views, as you can see on the right side of your screen. And now we're mapping the Fontan baffle. I usually begin by mapping the more easily accessible chamber for a few reasons. First of all, the arrhythmia might end up being there, so that's certainly important to rule out. But secondly, doing these voltage maps can give you a good idea of where a reference catheter might be placed. And thirdly, these maps could be used to merge with CT scan or MRIs. And so here you see that at the base of the left-sided Glenn shunt is a high voltage area, which could be a reasonable area to place a reference catheter. So we're just defining the anatomy here. We're now in the right superior vena cava. That's, of course, connected to the right pulmonary artery, as you see there. We are entering the intra-atrial baffle right now, circling it around. We're now in the left-sided hepatic vein, and we're going to better define as well the 2 IVCs. So there you have it, a voltage map of your Fontan pathway. And then that map becomes really useful in terms of image merging. And it's not, essential to merge these images for the purpose of mapping this easily accessible chamber, but as you will see shortly, this becomes really helpful when you're trying to gain access to more difficult to reach chambers, such as the pulmonary venous atrium. So it's important to carefully do this merge in 3-dimensional space, to look at it, again, in multiple views to get as accurate a merge as possible. Once that's done, we're going to go retrograde aortic, as you can see here. And so now the catheter is set to automatically rotate as we're going up the aorta. We're now in the ascending aorta. Catheter is, circling around there to define the anatomy. And once we get into the aortic root and really define the aortic valve, what I like to do is to tilt the image back to place that aortic valve in a type of clock face view, because in that clock face view, you can really aim the catheter at the center of that valve, and it usually then easily pops into the ventricle. So you'll see that shortly. We're now in the aortic root. We're soon going to define the valve, as you can see here, and then place the catheter just in the middle of that valve right there. We push it through and it enters the ventricle. And since we've already performed our merge, we've added here the ventricle and the pulmonary venous atrium, and then we just direct the catheter to the pulmonary venous atrium as shown here. So we're now creating a fast anatomical map of the pulmonary venous atrium through this retrograde aortic approach. We're spending quite a bit of time around the AV annulus. This was a common AV valve. We're getting annular points, but we're also carefully looking for His signals. We found a superior His, as you can see there, those yellow spheres, and also looked inferiorly because this anatomy is associated with twin AV nodes, but this patient actually only had one AV conduction system. So now the valve is cut out and you could appreciate the anatomy. Again, right and left superior vena cava, right and left pulmonary arteries, the intraatrial baffle, the two IVCs, the left-sided hepatic vein, and you can see its relationship to this common AV valve in the pulmonary venous atrium with two appendages that look like right-sided atrial appendages. Then, of course, we perform the EP study. And in this patient, just beginning with a drivetrain of 600 and one atrial extra stimulus, tachycardia was really easily inducible. And once tachycardia is induced, we go about beginning the mapping process. So what I typically do in mapping these arrhythmias is I start by getting points at remote locations just to get a sense of the arrhythmia in case it spontaneously terminates, and then fill it in and increase the density of points. And this turned out actually to be a non-automatic focal atrial tachycardia. We perform, pacing maneuvers for these types of arrhythmias. Entrainment is important, as well as propagation mapping. And here you'll note that this non-automatic focal atrial tachycardia was actually just adjacent to the Fontan baffle in an area of scarring that probably represents the site where the superior vena cava was transected from the atrium. So you could see the scar, and just adjacent to that non-automatic focal atrial tachycardia propagating in this pulmonary venous atrium. And then once we've identified the optimal site for ablation, we proceed with catheter ablation. And of course, we all like to see our arrhythmias terminate during ablation, as was noted here. So here you see, again, the area of scarring, probably the site where the superior vena cava was transected from the atrium on the roof of the atrium, adjacent to where the intraatrial baffle comes through and is connected to the main pulmonary artery. So after ablation, we continue to aggressively try to induce tachycardia, provoke other arrhythmias, target those if there are others. And if we've created linear lesions, we want to demonstrate bidirectional conduction block across those lesions as well. So I hope that this gives you, some idea of how these, procedures are done, from initial importation of CT scan or MRI images to connecting the catheter, to controlling the catheter, to the retrograde aortic approach, to merging the images, and a catheter ablation. Our next steps are to assess safety and efficacy on a large scale in both retrospective and prospective phases of a robotic PACES ISAC registry, and to assess the impact of our interventions on the lives of our patients in terms of various different patient-reported outcomes. So, ladies and gentlemen, that concludes our brief overview. I hope it's given you a better sense of some of the advantages of the technology and how it's applied in the clinical setting. Thanks so much for your attention.